I have no conflicts of interest to disclose. In case you missed the joke, there it is right there. The entire presentation is written by ChatGPT, and you'll be hearing a lot about that in the future. So let's see. The first thing it gave me was a slide that kind of defined what does geriatric mean in medical terms. Refers to medical care for older adults, an age group that's not easy to define precisely. Gerontology, the study of aging, including biologic, sociologic, and psychologic changes. Older is preferred over elderly, but both terms are equally imprecise. Let's define it maybe as 65 and above. That has some definitions by many individuals. What are geriatric symptoms? We asked ChatGPT. Falls, urinary incontinence, vision and hearing difficulties, weight loss, depression, poor memory, and poor self-rate of health. There's not much in ENT-related issues there, except perhaps hearing difficulties. Notice there's no rhinologic or even smell-related issues that are raised, at least not by this initial slide or the initial definition. Let's see if we can throw us a bone in a little different direction, be a little more positive. When I'm going to talk today about geriatric rhinology, I'm also going to be talking about otology, for those of you who do otology in the audience, and I appreciate your attendance if you do. Because remember, the ear is nothing more than another sinus. Just like the paranasal sinuses, the middle ear space is lined by pseudostratified columnar epithelium. It's an air-containing cavity. It just happens to have a very long ostium, referred to as the eustachian tube. And when that tube becomes blocked by secretions in the nose or sinus cavities, then you get, as shown here, some middle ear pathology. But geriatric rhinology is also laryngology. How many patients have we all seen in general ENT, as well as laryngologists, who come and complain of hoarseness, cough, or globus symptoms, which are related to a postnasal drainage? Again, a rhinologic source. So what are the geriatric ENT themes overarching this talk? Bioresilience decreases with age. That to me is just a good definition of the aging process. Tissues become less pliable over time. So if they're less flexible, you could say that they become more lax or they become stiffer. And again, an overarching theme when dealing with geriatric patients may be conservative therapy, especially in this age of polypharmacy. You see in so many geriatric patients, worry about drug interactions. Conservative therapy, but still effective therapy, whatever that might be. Some special considerations in geriatric rhinology: secretions thicken with age, allergies can worsen with age because of continued exposure, and the nasal anatomy changes. The nose lengthens, the tip droops, so you get poor tip support, and again, a septal deviation often will worsen with age. There is my transition right there. That is called origami, my favorite transition, as we move to a new part of the PowerPoint presentation. Here is a common patient that I think all of us probably see in our practices, no matter what our specialty. I keep hawking up this thick mucus. If we could solve this problem, we'd make a lot of our patients happy, no matter the age, but especially the individual of a geriatric age. So we're going to go over the history, the exam, and the tests, and the treatment options for such a complaint. Let's talk about this case. And I'm going to refer to this case as geriatric rhinitis. I don't know if you've heard that term before. That's a term I like to use for patients like the 82-year-old retired male bus driver who showed up in my office and complained of constant throat clearing for 6 months. It was thick, yellow postnasal drip. He did have some congestion as well, but he usually could breathe well through his nose. But when he lays down at night, that's when the congestion gets a little worse, and that's also when the drainage to the back of the throat gets worse. No complaints of facial pain or headaches. He thought his smell was okay. He did notice some ear popping individually, but had no complaints of coughing or hoarseness. He thinks that he might have environmental allergies, but isn't sure. He did try some over-the-counter sinus medicines. He's not sure which ones. They didn't seem to help well. So he's coming to his ear, nose, and throat doctor to try to get better. I'm going to stop now and open up the floor first to Dr. Parnes. Steve, any thoughts about this patient? Does it sound familiar? And what would your impression be, or your next steps, or any questions about the history?
Well, first of all, I noticed you were grappling with the definition of older or elderly. I have my own way of dealing with that. There are the three great ages of life. There's the youthful age, the middle age, and the boy, you look good for your age.
Or age, the older patient is the one that's older than you are.
This is the boy,
That's
you look good for your age, the 82-year-old. So I think it's important for, a lot of it has to do with education, to try to make these patients realize this is more of a physiologic condition most of the time rather than pathophysiologic. Some of these patients are seeing their primary care doctors. They typically have them on a nasal steroid spray. Also, they may use an antihistamine, which probably makes it worse because they're often dehydrated. It's just the opposite of how you treat them. So I think it's important to understand, what they come with and what they've been told, and I think try to counsel these patients. And that's how I think when they come to me with this complaint.
All right. Before we counsel them, anything else in the history that you're concerned about, or anything else you want to ask here? Let's say, for instance,
Well, I want to know. Right. I want to know I'm sorry. What was that?
Any tests you'd want to get? Anything? What would be your next step when you have a patient like this?
Well, of course, I'm going to, I'm going to do a physical examination. Of course, part of the history is I want to make sure they are, a lot of these patients, if they're dehydrated from too much caffeine, and again, the antihistamine thing, but, we'll do a full exam, of course, and I'll scope the patient, but usually you don't expect to find a lot on the exam.
Okay, let me stop you there, and let's say you're going to scope the patient. All right, there's a scope put in the patient. This is the right nasal cavity, 4 millimeter diameter, 0 degree endoscope. And so it looks like you can see a pretty generous inferior turbinate. And then you see a septum, which is kind of concave on this side. So there's probably a septal deflection to the opposite side, the left side. Let me show you another view as we go farther back into the nose. Here is what his nasal pharynx looks like. And again, or I should say his soft palate. So we're looking at the left eustachian tube over here, a little bit of the right eustachian tube there, the nasal pharynx. So we're all the way back along the floor of the nose. And what I like about this slide is it shows the two different forms of postnasal drip, if you will. Kind of the yellow thick stuff that patients often get. And again, I kind of think that's often coming from inside sinuses and dripping back. Whereas the thinner, clearer type of postnasal drip that the other half of the patients have, that I sometimes view as just coming more from the turbinates, although it doesn't have to be hard and fast, but that's sort of the way that I look at it. Here are both types. And it's just irritating the top of the soft palate. Here's a view of the left nasal pharynx. And again, this is the eustachian tube on the left here, the anterior cushion, the posterior cushion. And look at that thick, noxious drainage, if you will, maybe with bacteria in it, maybe not, but at least it drains over the eustachian tube and down into the oral pharynx, where it's swallowed or irritates the larynx and hypopharynx. And again, this is thought to be a cause of eustachian tube dysfunction in these patients. So there you've seen the examination, the nose, the posterior nasal cavity, and now the nasal pharynx. Again, I don't know if you have any comments or thoughts about this, or if any of the audience members have questions or thoughts. Feel free to ask if you'd like to. But I was wondering, Steve, would you get a nasal culture in this case? Would you get a CAT scan in this case?
I usually don't get a nasal culture, but I will get a CT scan. I think it's just to evaluate the sinuses and make sure there's no occult disease. I don't expect to find a whole lot of disease on the CT scan, but I think you should have at least a baseline CT scan. I don't think the nasal culture is going to be all that helpful in treatment strategy.
You'll get a baseline CT scan on the geriatric patient that comes in with complaints of postnasal drip.
Not always. It depends on how chronic it is. Sometimes it's a discussion with the patient. I'm not adamant. I don't have to get on every single patient. If they don't have really any sinus complaints, it's just post-nasal drip. That thick fluid does suggest that there's some possibly element of dehydration. You know, you're always torn between is it a post-nasal drip that's thin or thick? You know, you have the patient with the chronic rhinorrhea. They're really producing more fluid than normal, or is it that it's very thick fluid and they both produce symptoms, but they're kind of different symptoms? They said the one with the thick fluid is usually complaining of the clearing of the throat, and the secretions are very obnoxious to them. But then there's the one with a lot of rhinorrhea, and it can both be anterior and posterior. You know, they come with the drippy nose all the time.
All right, good point that I really didn't discuss yet, which is the complaint of, again, the anterior drainage, not just the posterior. But this particular case of this geriatric rhinitis, I just wanted to emphasize that such a common chief complaint, which is, again, that drainage down the back of the throat and always having to clear out that thick mucus, hawk it up, if you will. We have some other distinguished members in this audience just looking through. Dr. Eibling, Dr. Holbrook, I mean, it's just Dr. Hadley. We got a really august group of seasoned rhinologists here, even younger ones. Dr. Turner, Dr. Adams, feel free. If anybody wants to unmute and wants to ask questions, you are more than welcome to. You may disagree with some of the things that you just heard me say. And Dr. Parnes, you will not insult us if you want to ask questions or chime in. This is a video. It's kind of unedited. This woman's 67, so she counts as geriatric age. But just saw her in clinic this past week, and I thought, wow, this would be a great exam to show she was complaining of postnasal drainage, and she had a lot of it along the left floor of nose here. But it's the clear variety. It's not the thick yellow variety. She just had a whole posterior nasal cavity filled with mucus, and you can see it just running down, and there she's kind of trying to swallow just a little bit, but a really good example. Here's the right side of her nose. And again, she has the same thing on the right side of the nose. And I passed a suction down just to clear it out to make her feel better temporarily and to make sure there was no pathology in the nasopharynx that I was missing otherwise. And again, this is just red and that thick yellow. This is more of the clear drainage, but she has got a lot of postnasal drip. There she's got some banding from previous adenoidectomy as well. You can see some scar bands. All right, so let's talk about geriatric rhinitis. Let's talk about treatment. I want you all to take home a pearl today. I don't know what your pearl is going to be. It'll be different for everybody else among you in the audience. But on the other hand, you can't talk about postnasal drainage in the elderly and geriatric rhinitis without talking about nasal irrigations. So here's a picture I took of three very common forms of nasal irrigation. For many years, I just had my patients fill up a glass with warm water and a teaspoon of salt and take a bulb syringe, as you see here on the left. You can get any local drugstore and lean over a sink and just flush each side of the nose. But then, for 3,000 years, there's been the neti pot used for the thin, just for routine nasal hygiene, in the Eastern countries. And it's a matter of daily hygiene with the genie's lamp, the neti pot, if you will. But things were really revolutionized about 20 years ago when the NeilMed squeeze bottle came out, the NeilMed device. I didn't want to advertise NeilMed, so I turned this bottle around so you don't see the label. And of course, there are other brands that are now available. Even CVS and Walgreens all have their generic squeeze bottles, some pre-filled with saline and others in the packets, and you fill it yourself with sterile water or bottled water or distilled water or tap water or whatever you want to use. And but just so important. I mean, the way I look at it, NeilMed has done more for patients with chronic rhinitis than all the sinus surgeons in the world. It's just been a wonderful, amazing advance because it makes things convenient for the patients, not so sloppy. They don't have to make things up. It just makes it easy and convenient. This is a bottle of NeilMed. And this over here is the original NeilMed. Now, I took this picture at the Academy meeting because NeilMed was patented and invented by a pulmonologist, Ketan Mehta, who practices in Oakland, California. I know him pretty well. Again, I've never accepted a penny from the guy, but on the other hand, I just like what he does. And I stop by and say hello to him at his booth at each of the Academy meetings. And his son at the time was named Neil. And Neil was a little boy, and now he is an ear, nose, and throat resident at Wayne State. So there you get the original Neil that NeilMed was named for. You wouldn't know that he's famous, but he's a rock star to a lot of sinusitis patients. In the last 5 years or so, NeilMed has got a run for its money with Navage. So this powered irrigation system, even if you try not to have ever heard about it, anytime you turn on the radio, TV, internet, this company has, and Martin Hoke, who is the inventor and patenter of this device, must have hundreds of millions of dollars going in a marketing campaign because you hear him day and night. And it's been very, very successful. First, he was telling almost 1 million members, and he said over 1 million people have used this. Number 2 million. Now he's reached over 3 million in all of his ads. And lately he's been reading all the testimonials. Of course, he only reads the good ones, but he is a great, great marketer. And many of my patients have switched from NeilMed to this device, especially if they have thicker type of mucus, or they're just not happy with the NeilMed. They'll try this. Some of them won't be happy with this either, but others are. It's a powered system, so it has 2 nozzles, one for each nostril. And again, it's a motorized system, so rather than squeezing a bottle to flush the nose, the motor, of course, propels it one side, and there's suction on the other side. It goes back and forth as far as irrigate one side, then irrigate the other. But it's just a motorized form that does very much the same thing the NeilMed squeeze bottle did. Now, NeilMed makes its money not on the bottles, it's the salt packs that you sell. The salt packs are like an annuity for the Meta family. In the same way, Navage, it costs $99 in your local pharmacy or drugstore or wherever you go, big box store, Amazon. But it's the salt, liquid salt packets that you use for this device that they make all their money on. Because if you like the device, you have to keep using these salt packets that come with it. It's a liquid saline packet. But again, it's worked quite well. Again, if anybody in the audience, well, Steve, why don't you give me your comments about these 2 devices?
Actually, I don't have much familiarity with Navage, but with the NeilMed and bulb syringe and neti pot, I'm well familiar with that. I think that it's important to emphasize anything that has saline is good for the nose. I think in the Academy's consensus statements about treating sinus and rhinitis, saline is a unanimous support for that. There may be some controversy with other treatments, but nobody argues that saline is a great way to treat a lot of pathophysiologic conditions of the nose. So I think whatever you do, anytime you use any kind of saline product, it's going to be helpful.
All right.
Can I?
Yes.
Can I make a comment?
George?
George Henderson, yes.
Dr. Henderson.
Okay, I've been retired for a number of years. I was in private practice for 28 years in facial plastic, and I had my board in facial plastic and Otolaryngology. I worked at the VA for 15 years. You are talking about the best thing in the world is that NeilMed sinus rinse. When you showed that first thing up there, I would have put the patient on that. When I worked at the VA, I'd put people on this sinus rinse. They'd come back in, they'd be doing great. Somebody come back in and say, "Oh, I'm having trouble again, doc." Well, I just didn't want to do it. I do it twice a day. I've had more people on that. If everybody did that twice a day, I'm sorry to say, but we probably wouldn't have much sinus problems at all. It's the greatest thing in the world. And I'm glad to see you are talking about that because it is really the best thing in the world to keep your nose cleaned out. You clean your teeth out. Why not keep your nose cleaned out? That's where the bacteria and the virus and the pollens are. If you wash it out twice a day, they don't have time to invade the tissue and cause problems.
Dr. Henderson, where do you live? Where did you practice?
Well, I practice in Pinehurst, North Carolina.
No, oh, wait, I think you have a good golf course in Pinehurst, don't you?
That's right. And I'm almost 86 years old. My golf game is getting bad now, but I play golf, but I'm 86 years old, still active.
Well, good for you. I think you're going to have the U.S. Open in Pinehurst next year, if I'm not
That's
mistaken.
right. And it'll be the third one they had there. It's going to be next year. It'll be in Pinehurst. That's right.
So nice. You don't mind if I stop by and we can maybe get together? We don't have drinks. We can do
I
like
wish you would.
a irrigation together.
I'd love for you to come by. Are you coming to the Open?
I'll never tell. I might
I
drop
wish
you,
you would.
I
I
might
wish
drop
you'd
an
stop.
email sometime soon.
I wish you'd stop by and see me when you're here. I tell you,
Yeah, I'll beat you on course number 2, okay?
gonna be in course number 2. All right, that's right.
That's the one. All right. Thank you so much, Dr. Henderson, for contributing there. I
Well,
appreciate
thank
it.
you for getting that information because it needs to be get out to everybody out there. It's the best thing in the world.
Yeah, I agree. Although, again, Martin Hoke, who advertised Navage, doesn't think NeilMed's the best thing in the world, but they're both very, very good.
Right.
Because some patients like one and some like the other, but they are saline and they work wonderfully.
They really do.
They really do. And the NeilMed is less expensive, that's for sure.
That's right. Well, you can use a pinch of baking soda and a pinch of salt water. A pinch of baking soda and a pinch of salt is the same thing. And I did that for a while, but it's just not as convenient to do that.
That's right. Yeah. I say that same thing to my patients. You need the salt, a little pinch of salt to make it the right salinity that matches the nasal mucus.
That's right.
And you have a little pinch of the baking soda to make it just the right pH
Right.
for it. So but again, the packs are convenient and they're fairly inexpensive. Have you tried alcohol in any of your patients, Dr. Henderson?
No, I haven't. Actually, I don't, the only patients I have now, people I could come in contact with, I didn't use that when I was practicing. I did not know about that.
Yeah. Dr. Parnes, what about you? Have you tried alcohol in geriatric rhinitis? I've been really impressed with this. What do you think, Steve?
I agree. I've had patients who are very enamored with it as well. It's a nice product. Again, it helps keep the nose nice and clean. And I think it's another thing to recommend for these patients.
Yeah, now I think a lot of our audience may never have heard of alcohol. I never heard of it when I was practicing or training in otolaryngology on the West Coast. It wasn't until I came to New England I even heard of it. And when I say to my patients, you're going to put alcohol in the rinse, they say, I'm putting alcohol in the rinse. Can I just use vodka? I said, no, it's called alcohol, but it's like Vicks Vapor Rub that you would rub on for your nose, your chest. It cuts through mucus. It has the same menthol and eucalyptus ingredients and smells that you'd have in Vicks Vapor Rub. But again, you can get it over the counter in many, many pharmacies on the East Coast. And if not, you can get it on the internet. It's pretty cheap. And again, I tell my patients, just go in and ask the pharmacist and they can get it in within 24 hours if you don't see it on their shelf. But I have them take their regular NeilMed irrigation bottle. They put the packet of salt in the bottom and they fill up with some of this. There are instructions with it, but some patients just put a little, maybe like a 1/4 inch in the bottom of the NeilMed bottle. Others will do like a 1/2 inch, others a full inch. It depends what works for individual patients, but it just cuts through thick mucus. So those are really thick mucus. Again, those of you who've never heard of this or want something new for your geriatric patients who complain of postnasal drainage, try this. I think you're going to be pleasantly surprised. I've listed on here on this slide some other things besides hypertonic saline. Some people swear that that's good for thicker mucus. Others, baby shampoo, that's more for biofilms and really thick mucus. But I'm not been happy with that. My patients have not got a good response from that. The article is about Manuka honey and its beneficial effects. But again, alcohol is something that I really use and enjoy for my patients. Anybody else have any comments? Like to chime in? So here is my treatment paradigm for geriatric rhinitis. It's a pretty similar treatment paradigm for rhinitis in the non-geriatric age group. And you could say that it's not just for rhinitis, but for rhinosinusitis. So all we've talked about so far irrigations, and that's because that's what I strongly believe in. There's not the concern about side effects or polypharmacy interaction with other medications. If they need something else and they have a history of allergies, I do like steroid sprays. And I'll tell them they'll irrigate twice. I say you irrigate twice a day, just like you would brush your teeth. The saying is, You brush and then you flush. So after they brush and flush, then they put in a steroid spray once or twice a day if they need something else. And if I feel they have an allergic rhinitis component. Again, you can start getting to over-the-counter medications, but I don't go to those early on in the geriatric patient, nor do I go to antibiotics. If I think sinusitis is contributing to this, then I'll do as Dr. Parnes mentioned. I may get a CAT scan to be sure, or I'll put them on a trial of antibiotics even before getting the CAT scan. We'll talk about a little bit more about the more advanced techniques, including surgery for more advanced disease. But again, this is my stepwise treatment paradigm. Dr. Parnes, any thoughts about this?
Well, I would add one thing. It depends on the consistency of the drainage we talked about briefly. So if it's a more clear drainage, which they also complain about frequently, I'll add ipratropium in addition to like a steroid spray. I think I've had some success with that. That's more of a different kind of chronic rhinitis, but it is very common in the elderly as well. And again, we talked about anterior versus posterior drainage. I think the clear drainage is more of an anterior problem than a posterior problem. We'll talk about, I guess you'll talk about different aspects of that later.
No, I like what you're saying. I totally agree. Clear drainage is more of an anterior problem. Let's say the heads of the turbinates, especially inferior turbinates that are big and boggy. And the thick yellow stuff can be coming more from the posterior nose, especially sinuses draining in that direction. And I like ipratropium too. The problem is, again, in the elderly, you've got all the potential side effects from that. Everything, from glaucoma to drying, that's going to just, affect everything from their bladder and urination on down. So again, I don't mind using that, but I try not to go there with elderly patients most of the time if I can avoid it. But it's certainly in the armamentarium, as are antihistamine nasal sprays, as lasting, absolutely. Any other comments before we move on? Let's talk about some anatomic obstruction in these patients. If you look in their nose, and really if it's nasal obstruction they're complaining about, not postnasal drip. Let's just change nasal obstruction. So again, we've talked about irrigating, various sprays they can use, various medications. Certainly we haven't talked about antihistamine, decongestant oral medications, but we're all familiar with those, over-the-counter availability for most of them. Immunotherapy if they have a history of allergies. There are these, cauterization of the turbinates, whatever way you want to use, needle cauterization or any other technique. It's been around for a long, long time, and a lot of us do it in the office. Some newer ways of delivering energy and destroying tissue selectively in the nose. Rhinair, where, again, radio frequency delivered specifically in the nose, commonly the turbinates or the posterior part of the nose where the sphenopalatine fibers come in from the sphenopalatine ganglion. Clarifix is the same thing, but it freezes that area in the back of the nose. All in-office procedures, but again, I don't use them in the very regularly, especially not in the elderly. I like to stick with irrigations with most of them, sprays if we need to, and over-the-counter medications is the third step. But I really don't go up to these steps in a geriatric population.
Just the point.
Yeah.
Just a small point, Ralph, that a lot of these patients, it's rhinitis medicamentosa can be a problem. So
yeah,
it's always worthwhile asking them about their use of the oxymetazoline. It's not uncommon that they're unfortunately addicted to it. And of course, we try to educate them. I'm sure you do as well, but it's sometimes really tough to get them off the Afrin.
Absolutely. Inferior turbinate. There's a lot of different ways to handle inferior turbinates. You can take them to the operating room, but if they really can't breathe through the nose, so here's the left side. A common technique is with the microdebrider nowadays. If you just look at this left side, even though it's been all injected, lidocaine epinephrine, it still has a bulge on it, if you will, here due to hypertrophic submucosal tissue. So I just wanted to throw a bone here for those of you who want to hear more about surgery in the elderly. And again, a pretty simple, quick, non-invasive technique. Obviously, just the microdebrider blade, lots of brands are available of these blades, but you do a stab incision in the anterior or the head of the inferior turbinate here on the left side, and then you make a tunnel. The tunnel is really along the turbinate bone all the way posteriorly. And once you've made that tunnel, you turn on this blade, step on the foot pedal, if you will, or pull the trigger, depending upon the brand you have. And it's basically shaving out and suctioning out that hypertrophic tissue and the vascular tissue, submucosal space, without injuring the mucosa on the surface. So there's very little crust formation afterwards. And again, the complication rate is quite low, relatively non-invasive, but so you had a bulging turbinate. Now you have sort of a concave surface. There's still some bulging up here, so you can go back up and do, 2 or 3 passes until you're finally done. What about septal deviation in the elderly?
Ralph, can I make a couple points about
Yes, please.
First of all, I think that's the best way to address the turbinate. I don't have a debrider in my office. I often wind up doing it in the OR, often in coupling with of course, when we do a septoplasty. But I remember going through the literature. One of my residents did a presentation, and the conclusion was the turbinate reduction gives you the best and most consistent results. I mean, I'll do coblation in the office. I think it's a very nice technique, and it does help. But sometimes these patients need to have it done again after a few years. It's not as complete or as effective as a turbinate debridement. I also have I've also done a few things to avoid bleeding postoperatively. I like to make a tiny incision anteriorly before I put the blade in, because the blade's kind of blunt, and I'll use a caudal elevator to create the tunnel first, and that way I do less trauma to the mucosa of the turbinate, and then I cauterize my entrance point to again reduce the potential for post-op bleeding.
Those are all excellent tips. I agree with them all. How do you handle a deviated septum in an elderly patient where that's the source of the bleeding? Will you take this patient to the operating room?
I would. It doesn't look like a bad deviated. I mean, first of all, how many people have deviated septums? The answer is, I think about 80% of people walk around with deviated septums. So obviously, most of them I don't take to the operating room. I try to be more conservative. That's why I sometimes like to do an office turbinate procedure first. Okay. The person has a little spur, I notice, on the right. I mean, other than, Sluder syndrome, unless they have something like that, I probably wouldn't. I try to be pretty conservative, especially in the elderly. To take any elderly person to the OR, I try to be, as I said, more conservative if I can get away without doing surgery. But to me, the septum doesn't look too bad. I think with epistaxis, the same thing. You try a lot of conservative treatments first before you just decide, I'm going to move the septum back in the midline.
If it were a worse deviated septum, if I showed you another CAT scan and it were really a bad unilateral blockage, you would take a person in their 70s or 80s or early 90s if they had medical clearance from their primary care doctor to fix a deviated septum. Is that correct or not correct?
Yes, absolutely, I would. I mean, why? I mean, it's a quality of life issue. This is not usually a serious operation. If a patient really comes and they really complain, they're complaining, I can't breathe, I want to breathe better, and they have a severe deviated septum. I don't have qualms about taking an elderly person to the operating room and doing a septoplasty and turbinoplasty.
Fine. I concur. What about chronic rhinosinusitis in the elderly? So here's somebody, polyps or inflammatory disease of some type, and they have a classic history of, not only is their breathing down, but they're getting recurrent sinus infections and needing more than 3 courses of antibiotics per year, just refractory medical therapy, maximal medical therapy, appropriate medical therapy. Again, the same thing holds true. You will bring these patients to the operating room, quality of life plus medical necessity.
Well, yeah, again, what are the symptoms? I mean, what's the problem when patients have nasal polyps? They usually fall into 2 major categories. One is breathing, and the other is lack of smell. The lack of smell, they've kind of adapted to it, and it's usually not one of their complaints. But if they can't breathe and you can't reverse it with conservative treatment, then certainly I would go to the OR. I wish I had a debrider in the office because I think you could be conservative. And if it's just a small amount of pus, you can just take out some of the excessive polyps right in the office.
We
I used to
had,
use this.
yeah, I'm sorry.
was just
Do you
gonna
do
say,
surgery differently in an elderly person than you would in a non-elderly, like these two cases?
Not in the OR. I mean, I would try to open up, with neuronavigation. I would clean out the ethmoid sciences, may or may not spare the middle turbinate, depending on if there's a contrabulosa or a floppy turbinate. I think the advantage of doing a good clean out is then your conservative management topical sprays work better in the office.
There's a motto that I have when I operate on patients who are quite young, younger than usual, let's say in children or in the elderly, and that is less is more. I still will take them to the operating room, but less is more will always be in the back of my mind. That was a saying by Mies van der Rohe, a famous German architect, when he was talking about the buildings he was doing, and applies to sinus surgery in a lot of ways. You do as little surgery as possible, but as much as necessary. And that's really the art of medicine. And you just look at the disease and the whole patient and make that decision. But again, I take him to the operating room too, but I keep that motto in the back of my mind. And again, how do patients do that are greater than 65 compared to less than 65? There was one article published a couple years ago out of the group at Columbia and Cornell. And they looked at 89 patients. It was a retrospective study. But again, these patients, the geriatric ones, did better if you look at the same or better than the younger patients. Statistical significance, less blood loss, shorter operative time. Their SNOT-22 scores, the validated outcome measure for chronic rhinosinusitis, was better, improved more in the elderly than it did in the non-elderly. Again, this has the limitations of a retrospective study. This is a publication by Dr. Simmons, one of my fellows, as is Dr. Paz Lonsberg and Dr. Skangas. And this came out publication last year. We looked at a 5-year, this is a prospective study. Patients come into Mass Eye and Ear, they have sinus surgery, they fill out the SNOT-22 forms before surgery and then after surgery, up to 5 years after. So it's a 5-year follow-up in 338 patients. And again, even though we weren't looking at age specifically, all the different parameters we looked at, again, what made a difference in their outcome at 5 years? Well, those who had nasal polyps, environmental allergies actually did better. Those who had diabetes did less. But look down here at age. Age was not a significant factor. Again, we got just as good a result in those of higher age as compared to those of a lower age cutoff. So operating on the elderly who need sinus surgery is safe to do, and the results are as good, if not better, than in another population. Age. To finish things up here, I want to talk about smell, because this is a hot topic. And it's one that more and more of my patients are asking me. Doctor, I'm losing my smell. Does that mean I'm going to get Alzheimer's disease? Is it the start of dementia, a loss of smell? And smell in the elderly, geriatric smell loss, is a really tricky area for several reasons. This is a picture of one of my current fellows here, Dr. Dara Adams. She is in the audience right now, and her mentor at University of Chicago when she was a resident. And basically, what I want to say is that they have done an amazing job. Jay Pinto, her mentor, University of Chicago, is the senior author in this study, and he has done a phenomenal job. I don't know if he's here in the audience listening or not, but he has done a phenomenal job. And again, Dr. Adams was the lead author in this study. And notice it was published in the Journal of American Geriatric Society. So what better journal can you cite a publication for a talk like this? And this study, I mean, Dr. Pinto takes this database called NSHAP, National Social Life Health Aging Project. And again, looking at the database here, almost 3,000 patients. And well, let me just show you what the study showed. You have, again, these are home dwelling patients. They're not hospitalized, they're not seeing doctors. You go to their homes in this study, and you see their age range here, 57 to 85. And you give them this portable mental status questionnaire so you determine, is there an element of dementia or not? And part of this examination when you go to their home is you give them these sniffing sticks, 5 different odors to smell, so you know what their olfaction is like. And then you look at them 5 years later, and you see who developed dementia and who didn't, and what was the difference between those two groups. Now, again, Dr. Pinto has taken this database and done lots of studies, including Rhinology, but this one really caught the attention of the lay press and the public. The New York Times quoted it. He had lots of interviews on radio and TV. And again, 2 figures from it that are quite interesting here. So olfactory, if you look and see those that did have dementia and did not develop dementia, again, the baseline of this group did not have dementia to start out with, but they did 5 years later. And if you look at all these different factors, I mean, it's really olfactory dysfunction that is the one that has a p-value that's significant. It wasn't age, wasn't their sex, wasn't their race, not their comorbidities, not their cognition at the very start of the study. It really has to do with olfactory dysfunction. Look at that odds ratio, more than twice the likelihood of having dementia 5 years later if they had olfactory dysfunction. And not only that, but the degree of olfactory dysfunction correlated with the likelihood. The more smells you got wrong on those sniffing sticks, the greater the likelihood of having dementia 5 years later. I mean, that is a fascinating study. So again, older adults, more than twice the odds of having developed dementia 5 years later if they had olfactory dysfunction. Why? Well, first, that means that olfaction maybe is a non-invasive biomarker for dementia, maybe. And how do you explain this? So maybe the amyloid deposits that we see in Alzheimer's disease in the brain, maybe they begin earlier in the olfaction system than in the cortex. Again, just food for thought. And here gets the real bugaboo. This is another publication they had a little bit later, but looking at the same database. You know, if I were to ask you, how many elderly people have abnormal olfaction? I can't give you a number because it depends whether you ask the patient or whether you do objective testing, subjective versus objective. If you look at this table, the interesting boxes here, again, here's self-reported. Patients that felt that they could smell well and those that didn't, and measured olfaction with the sniffing sticks. Those that really did have objective and those that had normal smell versus objective dysfunction. And look at this false negative and false positive. So patients, you know, over 16% of patients said they had normal smell, but you tested them and they didn't. They had abnormal smell, olfactory dysfunction. And the opposite is true. I mean, almost 7% of patients who said that they couldn't smell well, when you test them, they could smell perfectly fine. So again, measuring olfaction in an elderly can be quite a challenge. And we really don't know the degree of olfaction dysfunction in the elderly. It's something that's really ripe for more study, more investigation. And again, its relationship to dementia is just fascinating. And this is just an area which is really a key. When you talk about geriatric rhinology, this is the hot topic. What do you do with the patient that walks into your office that complains of smell? Well, this has got a lot of press because of COVID for obvious reasons. So all the lay publics heard about COVID lose smell, and a lot of patients lose smell with COVID. Up to 80% of it get it back within 2 months after COVID. But again, we treat the COVID patients, at least I do, the same way I treat the geriatrics if they want it, and the same way I treat the post-viral anosmia patients. You give them olfactory training, which to me is no more than physical therapy for the nose. And again, patients can go online to Amazon, they can go to Etsy, they can buy it from NeilMed, about $35 for a set of 4 is the average cost of these odorants. They're essential oils, and they vary, but almost all of them have some floral fragrance, like rose is the most common, some citrus, lemon's the most common, some spice, clove is the most common, and that eucalyptus, we'll call it fresh or effervescent. And so the way I generally have them do it, Dr. Hummel out of Germany was the first to describe this. And again, it seems to really help if you put them on olfactory training versus a group that is not. If you do it early enough within the first few months of their loss, statistically significant number will get return of smell compared to those who don't have olfactory training. I know you can make a lot of arguments that it might be flawed data, but it doesn't hurt. It makes patients feel good. It gives them something to do. And twice a day, morning and evening, I have them smell first the rose for 20 seconds, and they stop and smell the lemon and the clove and eucalyptus. Do that in the morning and do that in the evening. And again, how long? Well, I have them do it for 3 months. And by then, most of them, they're going to get their smell back well. You can say 6 months, you can say a year, but that's the way that I do it. Usually about 3 months, twice a day. Steve, do you have any comments about that?
Yeah, I do. First, I agree wholeheartedly that the olfactory training is something you should offer these patients. I keep in mind these are observational studies. That doesn't mean that loss of smell causes dementia, but there's no question that it may lead to that, and there's concern. It's kind of analogous to the hearing impaired. We look at the same thing. There's been a lot of literature in that arena as well, where people have presbycusis, and perhaps if they're not treating it with, however, usually amplification, that may lead to early dementia or loss of cognitive function. I've been to some courses or lectures where talking about the patients with COVID-19, there's a concern that these patients who lose their sense of smell may have a latent loss of cognitive function. There's actually, that's been raised, that the damage is not just the olfactory nerve, but into the frontal cortex. So there's definitely concern about it, and there's some relationship.
Thank you. The video I show with the microdebrider and over 100 other videos, you can see at sinusvideos.com. This is a completely educational website that my fellows and I set up and maintain. Over 100 videos ranging from the most basic to the most advanced procedures. It's like YouTube for the nose and sinuses. You don't have to register, you don't have to pay anything, and they're all just very brief, edited, narrated videos divided in different categories. Feel free to take a look at that if you'd like. And the final slide, I want to invite you all to come to COSM the first week in May. This year, we're going to be celebrating the 125th anniversary of the Triological Society. As our keynote speaker, we have Dr. Rochelle Walensky, who is the director of the CDC. She will be speaking. That lecture will be open to not just Triologic members, but all attendees at COSM. That will be the 8 to 9 o'clock session on Thursday, May 4th. Come to Boston and celebrate. We're also going to be kicking off that year, the 200th anniversary of, that week, we'll be kicking off the celebration of the 200th anniversary of Mass Eye and Ear, founded 200 years ago. So a lot of celebrations, a lot of good times planned. We hope to see you in Boston. I'm going to wrap things up now. It's almost an hour. And Alex, I'm going to turn things back over to you. I'll stop my screen sharing and let you take over.
Great. Well, thank you everybody for joining our webinar that we hosted today for the American Society of Geriatric Otolaryngology. I'm actually going to post a link in the chat. I encourage everybody to join. It's free of charge. We host these webinars quite frequently, and they're always posted on YouTube afterwards for your consumption, and for anyone that might have missed it that you may think would be interested, please send to them. So I highly encourage everyone to join our great society. So thank you again, everybody, for joining. Dr. Johns, any other thoughts?
Number one, Dr. Metson, thank you so much for just a terrific, practical, engaging hour. And Dr. Parnes, for your insightful feedback. As the current president of the American Society of Geriatric Otolaryngology, I do encourage you to join. It's free. And if you like this content, stay tuned. We always have terrific speakers at our events. And Dr. Metson, congratulations on presidency of the Tri-Life Society. And wow, what a keynote speaker.
Thank you. Look forward to seeing you there, Mike.
Bye. Thank you.
Thank you.